This is a Behind the Paper podcast. Who gets a second chance? Survival, selection, and kidney transplant in South Africa. This is a Behind the Paper podcast sponsored by TTS. I am Dr. Macy Levan, the social media editor for Transplantation and Transplantation Direct. And today we're taking a closer look at a paper that forces us to confront one of the hardest truths in global transplantation, that not everyone gets access to life-saving transplant care. I'm joined today by Dr. Robert Fredericks and Catherine Manning from South Africa, who will be talking about their paper that studied 761 patients with kidney failure that were referred to a public sector renal unit in South Africa.
Okay, great. Thank you for having us. My name is Catherine. I'm a biostatistician working primarily on Prof. Elmi Muller's HIV to HIV transplant research, and I'm currently undertaking my PhD with a transplantation focus in the Eastern Cape. And the article that we're discussing today is the first paper on what we found, that transplantation improves patient survival in a PD-first program in South Africa.
Thank you so much. Appreciate it. I'm so happy you're here. All right, Rob.
Thanks, Macy. Thanks for having us. My name's Robert Fredericks. I'm a nephrologist based in Port Elizabeth, now called Gqeberha, in the Eastern Cape of South Africa, which is about halfway up the east coast here. I trained at the University of Cape Town in the Western Cape at Groote Schuur Hospital, and which also serves as our transplant referral center for the patients that are transplanted from this center. And I've been based here as the head of the renal unit at Livingston Hospital in the center here since 2012. And so all of the patients that are part of this research in Kat's PhD are from my unit. Thanks.
Well, thank you so much for taking the time today to talk with me. So I'm Dr. Macy Levan. I'm the social media editor for the Transplantation Journal. And today we're going to take a closer look behind the paper that kind of forces us to confront one of these harder truths in transplantation, that not everybody gets access, right? So kidney transplantation is the best treatment for kidney failure. That's a universal truth that we know to be true. But what happens when access to dialysis and transplant is limited from the start? So today's paper, Transplantation Improves Patient Survival in a PD first program in South Africa, takes us inside of a system where capacity is fixed and difficult decisions are made upstream, sometimes before patients ever make that wait list. And so this isn't really just about outcomes, it's about who gets a chance to have one. So in this context, PD first, this program is structured as a PD first model. So where peritoneal dialysis, which is home-based lower resource therapy dialysis, is prioritized over in-center hemodialysis for patients who are accepted into care. Rob, could you tell me a little bit more about PD first and that type of model?
Yeah, thanks. So in South Africa, many of the public healthcare systems centers are basically based on a peritoneal dialysis first policy. It makes sense for our country. We treat patients over a very large geographic area. PD is obviously a lower resource intensive therapy. It's got equivalent outcomes to hemodialysis, but we don't need necessarily a renal unit there, infrastructure. And so a lot of centers prioritize PD over HD for that reason. Notwithstanding the fact that, one also gets a good quality of life through peritoneal dialysis. And importantly, it preserves veins. For hemodialysis to create a fistula requires surgical access, surgeons, theatre time, all of which are very restricted in our country. And so it makes sense for us to prioritize a PD first approach, and ultimately patients who maybe cannot do PD would start on HD if they are accepted, or perhaps if PD fails along the way, they can then switch across to hemodialysis if resources allow.
That makes sense. Thanks for explaining that, because it's very different in the United States, and so I appreciate the context. So let's talk a little bit about your study. So your study followed 761 patients with kidney failure, And those patients were referred to public sector renal unit in South Africa. And I take it that is your unit that you run.
That's right. Yeah.
And the first finding that I saw, which was that nearly 80% of these patients never received kidney replacement therapy at all. Not dialysis, not transplant, nothing. So that's kind of a decision made at the very front door of the system, you would assume,
Great.
right?
Yeah.
So is there anything you want to comment on about that and how that happens?
Yeah. So it has been quite well described in the literature from South Africa in terms of the resource allocation process. Obviously, this is a really, really challenging, ethically difficult area for us as nephrologists. We train to help people. We want to provide everybody with the best chance. But due to resource constraints, we just can't do that. And so an ethical framework has been developed where patients are assessed by a multidisciplinary committee, which includes nephrologists, social workers, psychologists, managers, because ultimately budget constraints actually determine the number of resources available. And so patients are presented through this process in quite a detailed manner, which really includes a psychosocial assessment and all their comorbidity. And then they are prioritized into a system of either they are what we call category 1, 2, or 3. Category 1, basically a healthy patient with nothing wrong with them. They're young, a good psychosocial report, and it's just their kidneys, and they will be accepted. That's the understanding. But there are very few patients like that. Category 3 are kind of patients that maybe anyone might decide should consider conservative kidney care as opposed to dialysis or transplantation per se. And as you can imagine, many, many patients fall in the category 2 basket, where they are only accepted if resources allow. So basically, if there's space on the program. And this is obviously a big challenge for us working in this sector. As you can see, huge number of patients are unable to access appropriate therapy. And it's not just in our centre in Eastern Cape. This is really across the board in South Africa. All centres struggle with this and have the same challenges.
So, among those who were considered for treatment, selection isn't random. It's patients who were accepted tended to be younger, healthier, and better positioned to benefit from limited resources. Is that true, Catherine, from your statistical perspective, looking at that data?
Yes, that is correct. And we also deem them more transplantable, so more likely to get transplanted, which also leads us onto that finding that you might have seen that despite them being more transplantable, only 1 in 5 of those patients who started on dialysis received a transplant.
Wow.
Yeah.
Wow. So even those who kind of made it into the system, that path forward was still uncertain for them, and it's really only 1 in 5. So um, more patients died waiting than were transplanted in this study. And to me, that really means that being accepted into care doesn't guarantee access to the therapy that we know works best. So what do we do about this?
Yeah, if I can just chip in now, I mean, I think there's a huge need, obviously, to focus on primary prevention here, in our setting. But at the same time, we really have this tsunami of kidney failure coming our way, and it really is increasing over time. And so, we would be calling on policymakers to address the need to improve transplantation pathways and simultaneously, obviously, increase dialysis availability. There are some major challenges to transplantation in South Africa, although the expertise exists. The resources, as I mentioned earlier, things like theatre time. There are also social and ethical aspects in terms of there's no shortage of potential deceased donors, but to convert a deceased donor to a willing family donor is difficult in our setting. The law is very much on the side of the family in the sense that even if you're a registered donor, If the family says afterwards, no, we'd rather they don't donate the kidneys, then there's no donation happens. Also, there's a shortage of transplant coordinators in many centers in our country. There's a lack of ICU beds. So to accommodate potential donors, many patients who come in with advanced, so for example, brain injuries, we have a high rate of trauma in South Africa, but patients with advanced brain injuries are often not prioritized for ICU because the prognosis is deemed poor. And so this resource restriction really curtails transplantation at many aspects. I mean, I'm sure Kath wants to also chip in further there.
Yes, Robert, actually, you've said most of it. I just think that in my training, we always know that in public health, your best buys are primary prevention. So we almost need to turn down the tap that's going into the bathtub of kidney failure. So that's slowing down progression of chronic kidney disease, just because KRT is a very expensive treatment. So I think to start at chronic kidney disease, slow it down, and then, of course, perhaps increased transplantation would be our recommendation based on what we observed in our study, that we think patients are going to do a lot better transplanted than on dialysis.
And in your country, what does this prevention look like to you as a public health professional? If you could design a program that would help the public in South Africa understand things to do to prevent kidney disease, what would that look like?
I'm going to hand this over to Rob as a nephrologist, but I do know we were chatting about I'm busy designing a model that's going to estimate true end-stage kidney failure. And we were looking at the possibility of introducing treatments and how that would make the model change. And Rob, you were mentioning inhibitors, stronger hypertension control, genetics. So if you can just elaborate on that.
Yeah, thanks, Kath. I mean, I think South Africa has a unique let's say, convergence of kidney disease risk factors. We have a high rate of non-communicable diseases, particularly obesity and diabetes, much higher than many other similar sort of GDP countries to ourselves. We have an underlying genetic predisposition to chronic kidney disease in that there's a very high prevalence of APOL1 kidney risk variants in our population. And we have the world's largest HIV epidemic in our country. Although we have a fantastic freely available antiretroviral therapy program, as I'm sure you know well, HIV comes together with NCDs and APOL1 to drive kidney disease. So I think, it's not just a simple thing about addressing primary care, because I think we are still going to have a high burden. But having said that, Kath's 100% right. Hypertension control could certainly be much better. The primary care facilities, although in theory are there, are often poorly staffed. There's long delays. Patients have to wait a whole day to be seen. Sometimes there's drug stockouts. And then on basic things like we do have antihypertensives and diabetes care available freely, but we do not have SGLT2 inhibitors on the government medical supply, and that's a big problem. We know that they can certainly slow down the progression of kidney disease, and that's not there. I mean, apart from that, massive public education, getting people on board to lead a healthier lifestyle. We have very poor diet. Fast foods, high salt intake. I mean, there's really, really many risk factors, and I think there's a multi-pronged approach would really be necessary here, and really is important to introduce as soon as possible.
Because transplantation does dramatically improve survival, but only if you get to transplantation, right? So in the setting where resources are limited and there's strict selection criteria, the survival benefit still holds, and transplant isn't better. It really is life-saving, but we have to have a multifactorial approach to getting to transplantation, which ultimately means less people would need that therapy, right? And
That's 100%.
I think this is bigger than just South Africa, because globally we spend a lot of time talking about innovation, and you guys were the pioneers in HIV to HIV transplantation that we then were able to take to the United States and change our laws to allow that. But think about all of the new things that are going on, right? We have the opportunity in the future, very far out future, even though we're in clinical trials now for, things like xenotransplantation and organ preservation and doing all of these new kind of technologies. But right now, that's far. It's happening, but we are still constrained to what we have right now. And I think that your study and the work that you all are doing is reminding us that transplantation isn't really always about what we can't do. It's about sometimes we don't have the capacity to deliver what we already can do. And changing that level of capacity shifting and resources is really important. So let's talk a little bit about what you think should be the next steps for South Africa or other countries that are facing similar problems.
I'll start, Rob. I think data is really, really important. It answers questions. And I think that policymakers and people, stakeholders, they can't ignore numbers. And so Rob and I are really investing in getting numbers out of the Eastern Cape. So, for example, we were able to get a little bit of observational research, but this research has really helped inform microsimulation, which they're doing all around the world, where they're actually trying to predict actual chronic kidney disease and end stage for the countries using their population data. And so that's the next phase. And following that, once I've got all those numbers, I'm going to be running a cost-effective analysis, PD versus HD versus transplant, looking at different case mixes. So if we reduced HD and increased transplant, if we reduced dialysis and increased transplant, looking at all these case mixes to perhaps show that this could be a very important upstream intervention for kidney failure. Because, like Rob says, we would like to slow down the rates of kidney failure, but we're just not sure that's going to happen. So we also need to look at ways to increase our treatment rates. I think for me, the treatment gap, as I call it, those patients in kidney failure who are not receiving treatment is too wide. And so I think that getting the numbers out, and I think once you've got the numbers and you've got the epidemiology, it's something to work with, and hopefully it can drive change and especially help with policy.
Yeah, 100%. I mean, I think there's also, there's a few things that we can do as well to facilitate this increase in transplantation. I mean, we know transplantation is good on so many levels for the patient, yes, for society, 100%. These are young patients, parents, productively, economically, and it's cost effective. Mandatory referral of potential donors would really go a long way in our system. Implementing transplant coordinator presence in smaller hospitals, not just in the major centers, and introducing organ donation education into the school curriculum. It is happening. Fortunately, we have been privileged to engage more recently with the National Department of Health in addressing ways that transplantation can be increased, as well as kidney replacement therapy, perhaps more optimally with the current budget. Optimizing peritoneal dialysis over hemodialysis, for example, where if things are provided at scale, costs can be driven down. The whole idea behind this resource rationing thing was that only patients that are considered transplantable are actually accepted onto the dialysis program, with the goal of transplanting them to make space for others to receive dialysis. But as you pointed out in the beginning, it's only 1 in 5 that's actually transplanted over a period of time. So this is not really achieving the objective. But we are hoping that through constructive engagement with our National Department of Health, things can move forward. South Africa is in a unique position at the moment where the government is trying to introduce universal health care and trying to lessen the gap between the public sector, which is really 85–90% of our population, and the 10 or 15% self-funded, medically insured population, who receive, for all intents and purposes, pretty world-class care. We do have this unfortunate inequity in provision between the haves and the have-nots. And we need to, as a country, need to be creative in ways that we can lift up the public sector patients without bringing down, the care that's existent in the insured sector.
So it's about access, policy, education, infrastructure. You said something really interesting I want to go back to. You talked about organ donation education in
Yeah.
school. Tell me a little bit more about that.
Well, I'm not in a position to speak well about it because there are some civil society organizations that are doing a lot of good work on this, like Dave Thompson and the Orgamites Foundation, the National Kidney Foundation. This is from Canada, the Orgamites,
Hmm.
um, and a National Kidney Foundation, and other role players. And so there's some progress being made in using social media and getting into the schools and trying to introduce also into the medical training curriculum. We have a nascent medical school here at the Nelson Mandela University, where I'm based, where it's now been introduced. The organ deceased donor education course is part of the medical curriculum. So I think these things are, in time, we hope, going to bear fruit. But obviously, this is a long game here, and so we're still stuck with this barrage of patients that we need to. While we definitely need to address transplantation, and we definitely need to increase primary prevention and awareness, we still have this large number of patients with advanced CKD/kidney failure that do need help. Yeah.
Macy, if I can just add some numbers to Rob's points. I've recently collected data on the donor pathway for Groote Hospital from 2016 to 2025, and we had 814 referrals, of which 213 became utilized donors. And the greatest fallout was at the consent, with family. So if we're looking at organ donation, you've kind of got to plant the seeds quite young so that when you are approached with a situation, it's not completely new to you. So just to give you those numbers, which will be published within the next few months, but we've only managing to utilize around about 25% of our referred donors.
Wow.
Yeah.
Yeah, and I mean, to add to Kath's point there, on the living donor front, I can't give you an exact number, but it's only around 20% of patients that actually come forward as potential donors that are considered suitable to be living donors, due to the high incidence or prevalence, rather, of the comorbidities I've mentioned. Things like HIV are discovered. There's a huge prevalence, about two-thirds obesity. So this knocks off a lot of potential donors, really limiting the living donor program as well.
So are you doing transplants from HIV positive living donors or not?
Not yet in South Africa. I think
Okay.
it's very nascent. I believe from the States there are a few.
Yeah, we have a handful of cases that we've done, but yeah,
Yeah.
that's an interesting area that we're looking into understanding more. Um, how you can talk with people about that. How do you understand those options in HIV medicine clinics in the United States? That's an area of research interest for sure. So let me go back to the very beginning and ask a question I probably should have asked first, but what made you look into this to begin with? What led you to ask these questions to start with?
So, as I mentioned first, that I'm busy doing my PhD, and the broad question is increasing access to transplantation in the public center. So, it's quite a mouthful. It needs a lot of context. And in our opinion, the public sector healthcare is quite similar to a lower middle income setting, rather than South Africa is actually labeled as an upper middle income. But as you know, lower to middle income settings are synonymous with healthcare system challenges. And I was looking at a province that had an unknown population kidney failure, therefore a completely unknown KRT need. And so the first paper I realized in order to do all the very fancy modeling work, I actually needed observational data for the Eastern Cape and sort of using the Eastern Cape as this lower middle income setting. And so we got the data, and that was to answer the questions of those who make it to the referral for kidney replacement therapy, how many actually receive it? And this is to gain that first inference on the treatment gap, because South Africa has never been able to estimate that. We've only had kidney registries that tell us how many people in the public sector are receiving. It does not tell us how many are actually in kidney failure. And then also the study allowed us to follow up patients right from referral all the way to end of study and be able to look at their outcomes. And that was also another inference that we were able to see, wow, the transplanted patients seem to be doing much better, and we need to look into this. We need to extend this research a bit further.
And for you,
I
Rob?
mean, yeah, from our side as well. Yeah, we're really grateful to have Kath on board here, to actually help us get this data. But as a nephrologist working in South Africa, you can feel quite powerless sometimes. Dealing with the number of patients that we see who need help. And from a personal perspective, I think advocacy. This is for me a part of advocacy really, and in raising the awareness and actually getting policymakers to listen. We held in 2023, in the beginning of 2023, with Elmi Miller as her assistants, we held a symposium here at my local hospital, trying to look at ways we can increase transplantation in this area. I mean, should we even be looking at starting a transplant center, for example? What are the barriers? And really, one of the key things that came out of that meeting was the fact that we have no data. We actually don't, So, and as you know well, data speaks to policymakers, and unfortunately, policymakers don't fund data capturers. So in our setting. So it's a sort of a bit of a self-fulfilling thing, and we really want to break that cycle, speak out for the patient on the patient's behalf, and see if we can capture some attention here.
I love it. More data. We do need data to address these critical problems in the policy sphere, but it can kind of be a loop, right? Trying to support that data collection is really important. Would you
Yeah.
say that you have a robust data collection system for transplantation in South Africa?
Yes.
Rob, I think I'm going to hand this over to you. I think we need to talk about the
Yeah.
kidney registries because that is some of our only access. There's a few units that have published, and but I think Rob, if you can just speak about and explain our kidney registries.
Yeah, so I mean, there used to be a registry in South Africa, but fortunately, over the last 10 or 15 years, some colleagues from the Western Cape have actually reinitiated the South African Renal Registry, aimed at prevalence data really. And unfortunately, we I would say we do not have a robust data collection system in South Africa. The registry has made massive inroads and is really helping us a lot to understand the landscape. But we do not, for example, have mandatory data reporting from dialysis centers. So some hospital groups decide, it's not in the patient's personal protection of personal information, what we call the POPI Act here in South Africa. Then they don't report data. So that's a big problem for us because we actually don't have the denominator down. Unfortunately, also, most of the public health system in South Africa has no electronic health records. So we are paper-based, which really seems like, a century ago, but that's the reality. And so without data capturers and without an electronic health record system, our data is really poor. And I think what we are describing really is the tip of the iceberg. I mean, I think the number of patients that are out there is actually greater than what we've presented here, because only the patients that are referred to us over this study period were considered, whereas many people understand our criteria and they know this patient is too old for our program. They don't actually refer the patient. And so we have, I think we've got major challenges, and that's part of the the clinicians' burden here getting people to listen to us is we can't show them the number of patients that we're seeing. And that's why this work is really so important for us in really painting a picture. And Kath's work also going forward in modeling, the next steps to try and determine more accurately the true burden of disease.
Macy, just to extend, when I read research from the US, you have these giant registries where you collect unbelievable data. So I think in South Africa, what we see is very individual units sort of going through paper records, collecting, they decide maybe 5 or 10 years worth of data and then presenting their survival results. So it's very much individual unit based. We don't have big registries for transplant in place.
Do you think something like that is feasible in your setting?
I'm going to speak to Rob as the running a unit. I think you've got to have research people in place to do that data capturing. For what I've noticed working with clinicians, they have an unbelievable load to care for patients and just do their daily work. And when you add research on top of that and just data collection, it really isn't feasible or sustainable for the clinician to do it. And so the only thing that I think would work is to have research units where you have dedicated data capturers, funded data capturers that could collect all this data.
So that's what you'll
Yeah,
be doing once you finish your PhD, starting all of that for your country, right?
I would hope so. I've got a huge fondness for the Eastern Cape. I was born there. Rob works there, so there's more to this for me.
I love that.
yeah. I mean, I think it's 100% feasible, but it needs to be funded, and so, policymakers need to put money into collecting data because then we actually know what's going on and we can make the wisest policy decisions. So I think it's feasible, but it's not funded at the moment. So it's not going to happen unless our funders and policymakers actually come to the party.
And what is the most important message that you can share with your clinical community to inspire advocacy for that funding?
Yeah, I think we need to speak out, and so in the ways that we can in our own areas, keeping data like this is really important. Knowing just simple things like how many patients you saw and how many you couldn't help, and it seems really basic, to say that, but that information is not publicly available. And I also think that our patients, we as clinicians, we speak up for the patients, but because so many of them haven't got a voice, but they actually do have a voice and they don't use it. So patient advocacy groups, I think, are so important in our setting. And policymakers don't listen to employees, but they do listen to patients because they're the voters. So, if people do speak up in the public space about this and create awareness like that, I think it will actually be more meaningful than a bunch of clinicians shouting that they need more resources, because which clinician doesn't say that at any given time? So, I think that would go a long way to helping us.
Fantastic. Well, is there anything else you wanted to share about your paper or the findings that you want to highlight for the podcast that we didn't cover?
Um, Perhaps, Rob, we can just remind the listeners that Rob was involved in research about 2 years ago where we actually compared public sector to private sector KRT rates. I think it's a really important finding by our colleague Lungi. And they found that the prevalence of treated kidney failure was 49 per million population in the public sector versus over 1,400 in the private sector. And I think it was that the private sector patient and kidney failure, they have almost a 29 times the odds of receiving kidney treatment, kidney replacement treatment compared to public. So there's a really huge divide and inequality there.
Yeah, and I think, this is part of this advocacy work in trying to help people understand this massive treatment gap that we have, between the public and the private sector. And no one wants to bring the private sector treatment rate down, but we need to lift the public sector treatment rate up. And as we've been discussing, primarily it would be ideally through transplantation, but it just highlights the massive problem that we have. And so if you use that as a proxy of treatment rate for what's actually needed in the public sector, I mean, we're talking about thousands and thousands of patients in my area that are not receiving treatment that should be. So yeah, I mean, I think that was good you highlighted that. I mean, I think from my side as well, obviously our transplant outcomes were in this study really, really good. Probably an over estimate of the benefits of transplantation, in the sense that it's quite a small cohort. These patients are highly selected in the sense that they tended to be younger, with less comorbidity. So we don't expect that our survival rates are going to be as good as what's shown in this paper. It just happens to be that in this cohort that was how it is. But given our resource restrictions, I think we're still doing well with transplantation, and it shows what can be achieved. Even in a resource constrained setting, with attention to detail. We've got great pharmacists that make sure that there's never an interruption in the drug line supply. There are some good things as well in our public sector for these patients anyway. There's no co-payments for them, no out-of-pocket expenses. And these things are big challenges in other lower middle income countries where the drug supply is such a key thing. So there are some good things too. But it would be great if we could capitalize on all of that.
Fantastic. So patient advocacy, we need to do more of. Y'all need more funding for data collection and research in this area. Policymakers need to look at that data and pay attention to it and hear the voices of those patients, because the infrastructure is not capable of sustaining the need for transplantation and for renal replacement therapy in your country. So I would like to thank you both so much for joining me today, with Catherine Manning and Robert Fricks for joining me, talking about your very important work. You can read the full paper online. It's available on Transplantation Direct and will be linked in the show notes. I'm Macy Levan, and this has been a Behind the Paper podcast sponsored by TTS. Transplantation does save lives, but first you really have to be in a position to get one. And this has made it real clear to me that there are many places in the world that still need a lot of advancement in that space. Thank you both so very much. I appreciate it.
Right.
Thanks,
Thank you for
Macy.
having
Thanks
us.
for your time.
Yeah.